Right. So I'm going to be talking a little bit more about opioid use disorders in the perinatal patient, a little bit more broadly and not as nuanced as Dr. Adams' case, just because we don't have a whole lot of that. So we have our accreditation statement and policy. So our disclosures here. I have nothing to specifically disclose on this topic. We're going to review the risks of opioid use disorder in pregnancy, both to mom and neonate, potential treatment options. And then for those of you who are not aware of the Periscope Project, I'll talk a little bit about that resource that perhaps in combination with ECHO and the addiction hotline to be able to help manage these patients who are struggling with their management. So this is just pulled off from some headlines. So this is a very big topic right now, opioid use disorders, particularly in pregnant and postpartum women. Unfortunately, I also, well, not unfortunately, fortunately, I actually sit on the Maternal Mortality Review Committee for the state of Wisconsin, but unfortunately, opioid use disorders are one of the leading killers of our moms for both pregnant women as well as postpartum women. So number one among our white women is mental health and substance use disorders. That is taking our moms, our lives very, very early. Unfortunately, we also know that substance use during pregnancy is very underdiagnosed. Thankfully, in a lot of women, pregnancy is very much a motivator for cessation of substance use. However, if moms are unable to discontinue use of substances during pregnancy, it may represent a really high-risk subpopulation. So for those moms who continue to engage with substance use despite their pregnancy, very, very high risk. We also know that high levels of use prior to pregnancy correlate with continued use during the pregnancy. And unfortunately, even if women are able to discontinue use of substances during their pregnancy or bring their rate of use down, oftentimes they return to their pre-pregnancy rates of smoking and alcohol abuse in this study within about 6 to 12 months. This data is a little old at this point, back in 2014, but unfortunately the newest data we have out of state of Wisconsin, not surprising perhaps to anybody here that we're seeing increased use of both opioids and cannabis noted in women at time, in pregnant women at the time of delivery, opioids being that top orange line, marijuana being the green line just below that. I can only imagine that these numbers have continued to climb in the last 5 years or so. So what do we know about opioid use disorders in reproductive aged women? I always say that that's all I care about. That's what I'm doing day in and day out. But about 90% of female opioid users are in the US are of childbearing age. So in my book, that's between the age of 12 and 50. That makes some sense. Most women who are chronically using opioids pre-conception, unfortunately, do have a pattern of use into pregnancy. Perhaps, again, not at that same level, but there is some continued pattern of use. This data has been changing and is unfortunately difficult to kind of pinpoint because of lack of data specific to knowing the trueness of the data, meaning that moms may not always be reporting what their use is, and we may not be doing a great job of consistently screening, both verbal screening or validated screening tool screening, or utilizing a urine drug screen. So it's not exactly clear, but our best estimate is probably about 5 to 10, as high as I've seen in 1,000 births of mothers defined as being dependent on or using opioids antinatal. So unfortunately, this is associated with really high costs of both maternal care as well as neonatal care, particularly due to neonatal abstinence syndrome. So what we can see here, so this is looking at opioid detoxification during pregnancy. That's the first slides, as well as fatal and non-fatal overdoses among pregnant and postpartum women. You can see that that the risk of opioid opioid detox during pregnancy typically occurs in the second and third trimesters and then increases after there. And this is all, what this is looking at is the opioid events or overdose events, excuse me. So you've got the lowest risks actually kind of during pregnancy, but then the risk of overdose increases as the pregnancy progresses. And unfortunately, we see this with a lot of disorders that moms fall off the radar the further they get away from their pregnancy and delivery. They may engage in really good prenatal care, but usually by about 6 weeks postpartum, they may be dropping off of care. And then as we get further away, their risk of overdose and engagement in other activities increases. That's similar what we're seeing down below. The orange is overdose events while they're on pharmacotherapy, and overdose events not on pharmacotherapy. This pharmacotherapy was specifically looking at opioid antagonists and did not include naltrexone. But you can see that the overdose events were much lower for women pregnant and postpartum women maintained on pharmacotherapy throughout pregnancy and postpartum. So what does ACOG say about screenings? The American College of OBGYN, they have an opinion summary that really recommends universal screening at the first prenatal visit with a validated verbal screening tool. In the 10 years I've been practicing perinatal psychiatry, I feel like I've really beaten the drum on validated screening tools for depression and anxiety, and we're finally doing a darn good job of that. But I'm not aware of a lot of practices who are doing a great job of utilizing a validated screening tool. Most practices are asking, but not utilizing a formal screening tool. Does screen positive, recommending brief intervention, i.e. motivational interviewing and referral for treatment. Some of the tools that are recommended by ACOG or have been validated and looked at in this patient population that are relatively easy to incorporate into that initial prenatal screen. The NIDA quick screen questionnaire, the CRAFT questions, as well as the 4 keys for substance abuse. All of those would be very appropriate for this patient population. Why does this matter? What are the risks of opioid use in pregnancy? So we both see obstetrical as well as fetal risks. From an obstetrical standpoint, opioids are not felt to be teratogenic and carry a major risk of increased major malformations, although there have been some studies more recently saying that there may carry a slight increased risk. And a consensus at this point is that likely not teratogenic, however. However, it is associated with a host of other pregnancy problems, including preeclampsia, intrauterine growth restriction, placental issues, preterm, premature rupture of membranes, stillbirth or IUFD, as well as postpartum hemorrhage. And it's felt that that's likely to be related to the peaks and troughs with intermittent withdrawal. So as Dr. Brown had said earlier, a lot of the concern with maybe utilizing the naltrexone and when a mom had already been exposed to opioids would precipitate that withdrawal. And it's thought that that withdrawal period actually poses a very high risk to mom and to baby at that point as well. We also know that if women are continuing to utilize opioids or other substances, their lifestyle factors associated with use and relapse can also increase their risks of poor pregnancy outcomes, such as poor prenatal care, poor nutrition, or engagement in other things that may be positive impacts on the pregnancy. Similarly, with fetal concerns, opioid use in pregnancies associated with growth deficiency, microcephaly, neurobehavioral problems long-term, neonatal abstinence syndrome, sudden infant death syndrome. And that all of these are associated with an increase of neonatal morbidity and mortality. And oftentimes we're seeing a very prolonged hospital stay for newborns whose moms are utilizing opioids throughout pregnancy. So we've talked a bit about neonatal abstinence syndrome at this point. And what we mean when we say this is really this constellation of a lot of different symptoms, primarily central nervous system and autonomic irritability. They have a difficult time maintaining consistent temperature, blood pressure, and heart rate. They have a lot of GI distress and significant feeding issues. One of the biggest risks to these kiddos when they're experiencing NAS is that they don't feed well, they lose weight or don't gain weight, and they become a failure to thrive. And so that's really what we're targeting our use of medications for throughout pregnancy is trying to engage them in feeding. So that's something that we want to watch carefully. From a respiratory symptom standpoint, babies can struggle with respiratory issues. And what we can see is that this constellation of symptoms can have onset anytime within about an hour after delivery up to about 3 days. Our NICUs do a good job of monitoring these babies with pretty non-specific scales, unfortunately. And we do typically treat them most commonly with morphine at this point. And again, what our goal is to make babies comfortable, to allow them to have growth and feeding and to settle down that autonomic and irritability. Unfortunately, babies who are not treated for neonatal abstinence syndrome, that it can be a fatal syndrome for them. This is a study that was looking at opioid use and other pregnancy outcomes. So you can see along the left-hand side, looking at type of opioid, and then preterm birth, very preterm birth, low preterm birth. And really most any opioid use is going to have an increased risk of any of these pregnancy outcomes that they study here. And combinations of medications typically demonstrated the highest risk of poor pregnancy outcomes. So how do we treat these women? What is the gold standard at this point? And again, given our case by Dr. Adams, we can have some conversation about naltrexone and other options. But I would argue at least at this point, still the gold standard of care is opiate substitution. So it helps prevent the complications of illicit opioid use as well as opioid withdrawal. Time and time again, the women who are engaged in taking methadone or buprenorphine are more engaged with care. They have reduced criminal activity, and it really is a harm reduction type model with the utilization of those two agents. What we do know is that tapering MAT does not reduce the risk of NAS, and what it does do is increases the risk of relapse. So that's actually not what we're looking to do is bring down women's doses of methadone or buprenorphine. In fact, some women may need higher doses or certainly split dosing of either of those medications in order to maintain the same level of treatment throughout, the same level. Behavioral treatment is legal, and these women should be engaged in other behavioral treatment options. Detoxification withdrawal is quite controversial at this point. So women who are coming to you in first or second trimester of pregnancy and they're adamant about withdrawing or detoxing from opioids and not wanting to go on an substitute, that it's controversial, and at least at this point where the studies are at the least preferred treatment option. And the primary reason why is that it carries with it a very high risk of relapse when opioids are discontinued. Some studies have shown as high as 90% or more. So obviously the studies vary widely on that, but regardless, they're all very high rates of relapse. So studies that have had the most data has been methadone. Again, there's increasing data with buprenorphine as well as naltrexone at this point, but the most data we have is with methadone maintenance in treatment during pregnancy. And we've seen good considerations from both mom's side as well as the neonatal consideration. So from mom's side, it's quite positive. We see, again, improved prenatal care, increased fetal growth. They have a decreased risk of HIV, a decreased risk of preeclampsia. They remain in treatment longer with fewer relapses. Some things to think about from a pregnancy standpoint. So as women go farther along in their pregnancy, they have an increased volume of distribution. A nice way to say they got a lot of fluid on board. And so that oftentimes will necessitate a dose increase in their third trimester. And the other piece to consider with methadone is split dosing should really be considered as the pregnancy progresses. So typically second half of pregnancy. Now, obviously, you need to have a mom who's been engaged in treatment that you can give that second dose to, or have a setup to be able to feel comfortable with that split dosing. But ideally, we would have split dosing of methadone in the second half of pregnancy, or certainly third trimester. From a fetal or neonatal consideration standpoint, babies do have decreased heart rate and decreased heart rate variability. That is one of the markers that we see of how healthy a neonate is, or a fetus is that amount of heart rate variability. So methadone does tamp that down. They also do have slower breathing and fetal movements on a biophysical profile. So that's something that we do to monitor babies' growth, movements, and how they're progressing. So that is known when women are utilizing methadone throughout pregnancy. Obviously, there is that risk of neonatal abstinence syndrome. That's the same kind of syndrome that we would see when a woman's using illicit opioids as well as methadone. And that can carry with it some respiratory distress as well as some of the things that we talked about with NAS in general. So what about buprenorphine? So we're preaching to the choir about what buprenorphine is at this point. However, from a pregnancy standpoint, again, there's been more and more studies with buprenorphine. Women like it because, again, it's more of an office-based treatment setting versus a clinic setting. It has decreased sedation there, and we think that that may confer some protection to fetus and neonate. Also, similar to methadone, however, we do need to consider split dosing in pregnancy with use of buprenorphine as well. So that doesn't change between those two options. The best and first comparison of these two drugs, so methadone versus buprenorphine use, was with the Mother's trial. And this was several years ago at this point. And this chart from that trial is looking at methadone versus buprenorphine. And then on the first side, we're looking at total doses of morphine. So you can see that infants exposed to buprenorphine required a lot less morphine. They required less days in the hospital, so less NICU days, as well as a decreased NAS treatment. So that's all very beneficial if we think about it from both a baby standpoint as well. So it looked like, at least with these three, that buprenorphine was superior. And so what the rest of this article is looking at, that from a maternal standpoint, there didn't appear to be any differences in buprenorphine versus methadone for all of these things. So maternal weight gain, cesarean section rates, abnormal presentation, so breech versus not, use of other analgesia or pain control, positive drug screens, or medical complications at delivery. But as I showed you on that previous chart, buprenorphine exposed infants actually had similar incidence of NAS, however, shorter duration of symptoms, lower mean morphine requirement, and a shorter hospital stay. Okay, so the clinical significance of these findings wasn't terribly clear. However, all positive things when we were looking at buprenorphine as well. So after this trial came out, it was very much felt that buprenorphine was felt to be a very appropriate agent to be utilizing in our opioid use disordered patients in addition to methadone. So if the mother came and she was pregnant or got pregnant on buprenorphine, the thought process no longer was to get her switched to buprenorphine and vice versa, that we had good data with both of these drugs and wanted to maintain whatever drug was going to keep that mother well. So what about naltrexone? So again, less data as Dr. Adams and Dr. Adams-Brown and I have discussed earlier. So we typically will utilize naltrexone in patients who wish to eliminate opioid use entirely. The biggest issue with this in pregnancy, again, is making sure that that last dose of opioids was at least, excuse me, was at least 7 to 10 days from the last dose of opioids in order to precipitate withdrawal symptoms. So that's certainly true in all patients. I'm very mindful of that in pregnancy, given that risk to the fetus. Does not have abuse potential, although there's limited data in pregnancy, there is some growing data that Dr. Adams had alluded to. At this point, I think it's thought to be an option for women who have already had successful opioid detoxification. They're either pre-conception, they're on naltrexone, much like our case was, and wanted to be maintained on it. Or in the case of a woman who's already gone through detoxification, perhaps on her own, because sometimes we see that where they find out they're pregnant, they detox on their own, and now they're coming into care, and they're refusing to consider methadone or could be a real possibility for treatment in that case scenario as well, given the increasing data. However, the data is still little, and I do wonder, so this was in 2017, and this is comparison of naltrexone, methadone, and buprenorphine. So it's that naltrexone of an N of 68. I do wonder if that was the same studies that we were looking at. So you can see here This first chart is looking at anomalies, major malformations. And then this is looking at that same comparison and mostly pregnancy outcomes. Okay, so lots of data here to support or at least do some comparisons with our opioid substitution. Nothing in here that's terribly distressing to me. And as compared to our opioid substitution, you can see for those other comparison data points that we use for the mother's trial, the length of stay was much lower for infants exposed to naltrexone versus methadone or buprenorphine. Still increased though compared to the general population. Fetal distress rates remained about the same. And then admitted to with an NAS diagnosis, again, much lower than the general population, obviously, but not nearly the same rates as methadone or buprenorphine. So fairly reassuring with this comparison data. What about breastfeeding? So the American Society of Addiction Medicine does recommend breastfeeding for mothers using both methadone or buprenorphine. There's, again, limited data with naltrexone, but the data that we do have is also reassuring for that. It's present in low levels of breast milk. However, breastfeeding we feel is actually a very important treatment in treatment of NAS. So we've got a mom who's involved and wants to parent and wants to breastfeed. That can have very soothing effects, good skin to skin contact. And so those women who are interested and able to breastfeed should be encouraged to do so as long as they're not actively utilizing other substances or engaging in illicit substance use. So intrapartum management, so this pain control piece. So I think awareness is key, is the biggest issue, is in having some planning and forethought, much like what Dr. Adams had for her case, and really identifying what your pain control plan should be well in advance. My focus here is going to be for buprenorphine and methadone. We need to remember that buprenorphine and methadone are not analgesia, and that these women are likely going to need more analgesia during labor than non-opioid dependent patients. And giving opioids, to treat their pain does not cause relapse. And so we need to be very mindful of that piece. Buprenorphine with their mu receptors tightly bound, will likely need higher doses. We should be avoiding opioid antagonists, such as listed here, because that can precipitate withdrawal as well. And pediatric staff should absolutely be available, aware. And my hope is that they have been involved pre-delivery as well. So we certainly have our maternal fetal medicine docs on board with these patients, and have NICU staff available and aware of these patients from a delivery standpoint. Document. Smart phrase everything. If you're an epic, that's my favorite thing to do. So document and collaborate. Why you're doing what you're doing, why are you choosing what you're choosing, and then collaborate with everybody. I think particularly in mental health, unfortunately, we may have a system set up so you may be set apart from the primary OB providers, maternal fetal medicine, the methadone clinic, the buprenorphine prescriber. And so as much as we can do to document and collaborate these ongoing conversations very early on with all of that patient's providers, that hopefully is going to give the best option for outcome of the pregnancy. I'm just going to take a couple of minutes for those of you who are not aware of the Periscope Project to let you know what we're doing. So the Periscope Project is a free resource for any healthcare provider or healthcare professional who is caring for a woman who is struggling with a disorder. We do that by providing three primary options. So the first is real-time provider to perinatal psychiatrist teleconsultation. The second is providing educational presentations and downloadable toolkits and videos available on our website for anyone to see and utilize, as well as information on available community resources that are specific to the perinatal population. So the first of these options is provider to provider consultation, and this is the most commonly utilized option that we have. About 80% of our calls are for our provider-to-provider teleconsult. We have a 1-800 number as well as an email address. We're available Monday through Friday, 8 to 4 Central Time. And a provider is then connected with a perinatal psychiatrist within 30 minutes. Typically, people are calling about psychopharmacology questions or substance use treatment, but we also field phone calls about diagnostic clarification, interpretation of screening tools, as well as follow-up recommendations. Community resources can be accessed through our triage coordinator. When I've been practicing in the Milwaukee area for about 10 years now, and what I learned as I was helping to create this program is that I knew of a lot of community resources across Milwaukee that really did subspecialize in treatment of perinatal women who were struggling with mental health disorders. However, they were so siloed, I could never get that patient, the right patient, to the right resource at the right time in an efficient manner. So what our database does is bring all of that information together. We have resources really across the state at this point, and that includes psychotherapy providers, AODA treatment centers, peer-to-peer support groups, as well as other perinatal psychiatrists such as myself. A provider can call the resource, call our triage coordinator, and then these resources will be provided via email to the provider, and gives really the name, description, location, as well as the best way to establish with the resource. We follow up with them on a yearly basis to make sure that we have the most updated information about that resource. This is how it works. A patient or a provider calls the triage coordinator at our 1-800 number. If you're already enrolled in our program, that triage process is only just going to take a couple of minutes just to gather the information of what you're hoping to learn from or connect with. So if you're looking for a community resource, that triage coordinator will provide that to you immediately. Otherwise, a page goes out to the covering psychiatrist. That covering psychiatrists on average, so we've been operational 3 years now, that average call return time is about 6 minutes. So we're really doing we're trying really hard to get back to providers as quickly as possible, so that we can provide them with the knowledge, expertise, and case-based discussion that they're looking for. And so then we have a case-based discussion, about 10 minutes on average, much like you would have in the hallway. You see a colleague in the hallway and say, hey, I just want to run this case by you. What are your thoughts? So that's exactly what the Periscope Project does. The provider then, oftentimes the goal is to keep that patient in the care of that provider. The provider is going to discuss treatment options with the patient, and then patients will remain in the care of the inquiring provider. Lastly, we have provider education and online toolkits that's available at our website, which is listed there. We also have video modules, so much like what I'm doing right now, slide sets with my voiceover to give you more education about various topics related to perinatal psychiatry. Other didactics or grand round presentations. I say in person, that should be air quoted, and virtual at this point because everything is virtual, are also available upon request. So a couple of conclusions that I just want to make sure everybody kind of comes away with. Neonatal abstinence syndrome occurs in the vast majority of neonates with in-utero exposure to opioids. That's both illicit opioids as well as methadone and buprenorphine. Really, the standard of care is opiate substitution. That the American Society of Addiction Medicine recommends breastfeeding, and that both the Periscope Project and Accept can really help support your perinatal patients who are struggling